not at any faculty of medical sciences. So I know the European policy making, but I don't know anything about medicine. Actually, my wife, she's a dentist, so that's all that I know about medicine. I will give you the floor, and I would like to ask you, I think it's better if our speaker will be on the public. Actually, I will also be sitting there in order to see the presentations. You can...
Apologies, could you unmute yourself, please? Thank you.
Okay, sorry, ezt a mikrofont ezt bekapcsolom. Sorry. It was only the introductive part.
Ezeket egy kis...
In front of the... we need this one also, maybe, for the streaming. So you can present at the desk or before the screen, as you wish. And as the time goes on very quick, I will let the floor for our first speaker, Professor Eliza Mustone Alexander, who is coming from Ireland, Royal College of Surgery. Royal College of Surgery. Surgeons in Ireland, sorry. So please, Professor.
Let's see if I can get this to work here. Can you see if this is working?
Yes, it should.
Oh, there you go. Okay. Thank you very much. Good morning, everyone. I hope that you had a pleasant evening last night. It was quite fun.
Just a minute for the camera. We will put you on image. Perfect. Thank you.
So my time with you this morning is brief, short, and I will get to my presentation right away. So I am a physician associate, and that is a new profession in Ireland. But I come from America, and I was a physician associate in America for over 40 years. I started my training when I was 2 years old. I had a long career in clinical medicine and education. And I moved to Ireland 4 years ago to begin the Physician Associate Program at the Royal College of Surgeons. My talk today will be about our progress and some updates around our progress towards regulation, because health professionals across all countries generally are regulated by the government for practicing as a healthcare provider. So I will talk to you a little bit about the educational model, where we came from, how we are a driver as a of the stakeholders to try to help them understand what our role is, the scope of the role. We've demonstrated it through pilot programs, advocacy and education, and looking at
I don't actually speak Hungarian very well. It's a complicated language.
Because your name I was not prepared.
Can I minimize this? Oh, great. Fantastic. Okay. Is this? Oh, I have to. Okay, fantastic. Great. Good morning, everyone. My name is Samira Jabakhanji. That's how you pronounce it, but I don't blame anyone who just calls me Samira. That's what I prefer. I'm a postdoctoral researcher at the School of Population Health and RCSI, and today I will give you a little bit more of the research side of what RCSI has been doing to adopt a policy-making mindset. So I'll be focusing on chronic disease because what we see in Ireland is that the prevalence is really high. Depending on which studies you look at, for diabetes we see a prevalence between 3 and 6%. For obesity we know that the prevalence is among the highest within Europe, so there's a real need. And this is why 2 years ago the Centre for Chronic Disease and Population Health Research, also called Converge, was brought into life. And the aim is to conduct and communicate complex chronic disease research that is impacting national and international policy making, and trying to do this in a very multidisciplinary way in terms of stakeholders and methodologies. So this is just trying to give you a bit of an overview of what I'll present today, very briefly today. Here in relation to diabetes, we pulled together a global monitoring framework, and now we're working at hospital care indicators for diabetes together with the World Health Organization and international experts that they brought in. Out of this project, we also developed a living systematic review of diabetes targets. And then I also will present a little bit about the Cobweb Network on Obesity, which is an initiative that was brought into life by public health researchers, clinicians, health economists, and we also have a patient advocate on the program. And this later on, after we've been working together for a while, actually gathered interest by the European Association of Studies on Obesity, the WHO, and we also have local and national policymakers involved now. So what we see, what I really like is we see that public health researchers are in the center of all this. But when we compare the two projects or initiatives, we see that, well, one very much developed top-down, where the WHO kind of commissioned the work to us, whereas the other one was really bottom-up from, well, kind of us here working together and deciding we wanted to collaborate, and then at some point attracting policy interest. So just briefly about diabetes. The WHO Global Diabetes Compact Initiative has been around for a few years now, and it is an initiative to support people living with diabetes. And as part of this, we developed a global monitoring framework together with the WHO. And the goals were to kind of standardize the way that these indicators are being monitored, international surveillance, to their policy development and progress tracking of targets. And then, well, this can obviously inform resource allocation. And here we were really much taking advantage of the WHO Technical Advisory Group on Diabetes. And we were working together with them to develop the framework. And our whole process, now this is a complicated way of, before we talked to these experts, we had internal discussions, we developed a draft framework within the smaller team of WHO experts and researchers. We then conducted a systematic review to identify indicators that might go up on this framework. Then we put indicators forward to the experts and had two experts were ranking the different indicators and thereby deciding which should be prioritized. And then this led to the development of, and unfortunately I can't framework today because there's a still embargo, but we went from I think 178 initial possible indicators down to 45 in the framework, and we also put together a document which contains metadata for each of these indicators, where we give monitoring this, how the definition, how it be recorded at the level of disaggregation, for example, by sex or by type of diabetes, and where actually these information can be found within countries, so that people who are in charge of monitoring can actually bring in the data into the system. We're currently also doing a similar project in relation to secondary and tertiary care indicators in relation to diabetes, at the conceptualization phase, so I won't talk about this more, just to mention that it's a very similar process to the first project, and public and patient involvement a little bit more in there as well. The third diabetes project that we're conducting is a living systematic review, where this is also part of the initial Global Diabetes Compact work. They pulled together this framework of targets, and we picked the biomarkers and behaviors to focus on for the first round of reviews. So we're looking at the reported prevalence of glycemic control, blood pressure control, lipid control, and statin use across the globe. We are also looking at variation and inequalities both within and across countries. We're looking at how comprehensively these indicators have been reported and where gaps in monitoring are. This is our published protocol in case you want to know more about it. We're currently at the full text review stage. We've pulled in loads of medical students to help us, which was really good. And so far, we already have more than 200 papers included for data extraction. So I'd say it's going to be fun, and bear with us. It might take a while until we see results. And just to give you an overview of the obesity work, this developed very differently. It started at a conference like here. We were in Iceland in 2019, and a couple of people just joined forces because we realized we have similar interests, are working in similar areas, and well, we should get together. We should get more people to work on this. Or, well, hold on, probably more people are working on this. Who are they? Where are they? So we joined forces, applied for a symposium presentation at an obesity congress. We're very unprepared, that's how we felt, but actually got really good responses to that. And then that's what we kept on doing. We presented at conferences, we organized symposia and workshops, and this is how what we're still doing. The reason for this was we realized that, well, people do know how to model weight and the outcomes associated with it, the costs, but there's not a lot of awareness of these models. But also we see that the research that's behind it is really lacking. Like the data are often inadequate, or the methods are. So this is an area that needs to be developed a bit more. And also we see that these models are really just underused, whereas they're a really good tool for decision making in this area. So obviously we need to bridge research outputs to political action and link researchers, clinicians, and policymakers to come together and talk to each other. This is why we developed a workshop that was a year ago in RCSI, to also bring in stakeholders from outside the network and talk to each other. And it was a 2-day workshop. I won't go into the details in the interest of time, but we had several kind of interactive exercises and expert presentations in there. And what we saw coming out of it is that within just a few months, our membership grew from 15 to 45 members. Out of a sudden, we see more and more countries getting involved, also those with less research kind of intensity. We see that out of a sudden the WHO and the IASO are contacting us, are interested. We are collaborating with NICE in the UK now, and we also have a series of academic outputs. For example, we have publications underway. There's more ideas for research and funding applications, and we are organizing a webinar series every 3 months now. So this is actually a really fun way that now we have our own event that is regularly taking place. So just a few quick learnings. When we compare the two, we see that one is the kind of top-down collaboration, whereas the other is more bottom-up. The top-down one really came into life because there was this opportunity. There was need on the one side, there was expertise on the other. So this is how we all came together and started working together. And I think the project really benefited from both sides coming together there. Whereas the bottom-up one, it was just really a handful of people at the start, similar ideas, but really few people. But we managed to create like some group identity, grow in visibility. We used seed funding. We were really seeking more connections. And we were, as I would say, they were taking the leap. We were just pulling together this workshop. We started a website, which is very basic. It does not look very professional, but we have a website. But really, we struggled with having very limited funding, and it's very people dependent. So these are the bottlenecks here. We also see, though, public health really is at the core of both of these collaborations. And just a few top tips if you're interested in growing more collaborations. I would say talk to the outreach offices. Roisin here, thank you, you've been great help. We could not have run this workshop without you. Go expose yourself, find other people who are working in similar areas, step out of your comfort zone, come to conferences, talk to people. Also, if your ideas are not perfect or they don't seem perfect to you, you will get kind of feedback from and then out of a sudden, them together. Speak to policymakers. The way we engaged with the WHO was I walked up after a plenary session and just introduced myself, so this was relatively easy. And now we have a call with them every now and then. Create a group identity. I think that helps, having a name, having a website, having photos up there and bios, having an email address so people can contact you. Something we struggled with for a while was the responsibilities within the network. So now we have a board with regular board meetings, but we need to be very flexible, especially when 15 to 45 members in just a few months. Well, things change. We really have to kind of adapt. Clear about your objectives. That's something you all the time, and new people coming in kept on asking, what's your goal, what's your goal? So have goals set. Be creative. Maybe you can engage with another area in some forum and experts in other countries, in other universities. And well, the last thing is really just pitch your ideas to everyone around you, because people will remember you, especially if you have a name. Now everyone knows I'm chair of COPWeb, and well, thank you for your attention. Sorry, it kept on slipping.
No problem, I think. Thank you very much. It was very dynamic. Now I see have this level of and in order to have some time by the end for remarks, I will quickly pass the floor for our next presentators. We just have for the use this one. This is yours. So the floor is yours.
Will that work? Okay. Thank you very much. Hello, everyone. My name is Irena Dus-Ilnicka. I am associate professor from Wroclaw Medical University. And you might find yourself a little bit puzzled because usually when I was doing some of the presentations and I was going abroad, I was speaking always, oh, I came to you from a country far, far away, like John Paul II said usually. It's quite improbable to say it in Hungary. So let me just say that I'm from Poland. And this is a skill. This is how we are going to proceed today. Firstly, I would like to introduce you to you. Oh, okay. Us, and I hope also the whole group. We will delve in the details of how our medical professionals taught, and that will be an example based from Poland, but also I think probably in most of the European Union. I will try to answer, at least ask, if not answer, the question, is there general recognition of medical skills? And is there a policy making based on medical universities' experience any possibility for the future? So without further ado, you might see that we are now representing most of the universities that are medically profiled. There was our RCSI, our great friend already. There will be Holger from University of Humanitas. We already know each other very well, but you might not know us yet. If you haven't been during the associate partners meeting, then that's the moment probably that I will come back to those presentations. And we are forming the medically profiled associated UGLO universities, which are the group within the group. So, and we are very happy to be here with you and share our experiences on the long-term strategy and overall mission of UGLO that is being implemented within our framework and with the use of UGLO tools that we are very happy to go further on. So as you see, similar mindset, and we have a very similar idea for how the UGLO mission could be evolved within medically profiled universities. And that's our university. We are based mostly inside of, as you can see, our heart lies there. And that's the localization of the region is Wrocław. most of the Hungarian people would probably know where it is. It's not far away from the border with Germany and Czech Republic. And we are and as I could say, our university is only one medical university in the region that is focusing on medical structure of professionals. And the region itself is of 3 million people, so you might find that's a quite big challenge. We have 4 faculties: medicine, dentistry, pharmacy, and health sciences, and 2 hospitals that are specifically specialized in that area. If you want to delve a little bit down, we have also some great history behind. There was Alzheimer and Ludwig Hirschfeld, who were also part of our university. So we comprehend all of the history that was also behind of that. Yes. But if we have the broader look, you might see that we are a border of European Union. And that is the part that's quite important for us nowadays within giving the changes in geopolitical structures. And that has been already very much of a challenge during recent times. And that's the data that has been provided by United Nations. Poland remains the main country of arrival for refugees from Ukraine, with more than 3.5 million having entered the country. That has changed a little. Now, from the newest information, we have 1.5 million because of changed geopolitical situation and goes back and forth. But also, please keep in mind that some of those refugees might never enter any other country of European Union because of the similarity of the languages. Polish is the first of the Slavic language that is very similar to Ukrainian. And for that, I think, and we see that some of the refugees don't never want to go in any other country. And that brings not only our third mission to completion, but that also extends the third mission over the thinking that people that come, that they flee the war, but not poverty. So in that case, they want to continue their life. And what we have here, there are some examples that you might see that we already done. Most of your universities surely and your institutions have been surely very much introduced within the same ideas. But because of the action that Poland has been given within the first times of the crisis in Ukraine, there was the International Scientific Conference of Magna Carta anniversary that was held in 2023 because of Poland's role during the migration in Ukraine. But if you might see, one of the NMT tests, so National Multi-Subject Tests for Ukrainian, see, I already think about them in the same way, Ukrainian students that want to pass the exam test and are not able to do so in their country, we've provided as a university the places for them in order to do those tests and be able to initiate their studies in Poland. And if we are speaking about studies, we'll go to the second part of the presentation, how are medical professionals taught. I would start with the nursing because that's quite of a challenge everywhere. Lisa has already included us within the subject how this is important. And I will, so the first part is, let's say that we understand most. Universities that are teaching in different fields. There are comprehensive universities, there are faculties of nursing, and there are medical universities that are specifically profiled from that purpose. But that doesn't finish there. I have to somehow understand how, okay. Doesn't finish there. There is higher education teaching that it's not stopping in that. You have nursing colleges, technical institutes, teaching hospitals, and health service training centers. If you already think about the complexity of that, it's already going to, even if you have a policy for how does nursery students have to be taught, there is already a basis that all of those are going to be a little bit different. So imagine about recognition of credits. If we're going in deep for teaching medicine and dentistry, mostly it goes through 2 possible ways: faculties of dentistry and or in comprehensive universities, and the medical universities themselves that are teaching the subjects. And if you go and see how Poland works, we have 9 medical universities, so specially profiled. Then there are colleges, 3 of them, that being honest, I quite don't understand how that's the difference, but okay. 5 university faculties and 2 faculties of non-public universities, let's just say private-like. So if we look again at the picture that I've showed you at the beginning, if Poland is a border of European Union and the majority of universities are non-comprehensive universities that are teaching medicine, dentistry, nursing, let's just stop there. The voice of those universities within the recognition of credits might be one of the most important, especially given the geopolitical situation. So is it important to hear us? So within that, I will show you how some of those were implemented based on our experience that our government has already implemented because of that. Before I go there, you know already that there is a European degree mission and possibility for the strategy. I would say that how could I say, I hope it's going to be successful, but if we just read the definition, a new type of degree awarded after transnational bachelor or master, automatically recognized everywhere in the EU, awarded jointly on a voluntary basis, and based on a common set of criteria agreed at European level. So my question is, do we see it happening for medicine, dentistry, and nursing in all of the countries jointly? And let's just leave it unanswered. But if not, what are the other options? So the other options are European professional card that you already surely know. It's an electronic certificate that simplifies the recognition process for some professions. And that's how it works for nurses, pharmacists, physiotherapists. So it's actually working throughout the European Commission site and seems to be a very straightforward part. And again, we have currently the procedure for issuing the European professional card covers the following professions. This is nurse, pharmacist, physiotherapist, mountain guide, and real estate agent too. That might be a very important question. We have many mountains in Europe. That's a very important part. So what are the general care nurses, the automatic recognition in Poland then, if you would look at it? There is, if you're trying to, this is the print screen from our governmental site, that it's, as you see, this is you can apply for the recognition throughout our governmental site because of the experiences that we already have faced. And there is at least 3 years of full-time study and 4,600 hours to be complied. And the general care nurses must demonstrate at least 3 years of professional experience. The doctors working in Poland, so medical doctors, that are fleeing Europe, fleeing Ukraine, in Poland can apply. If we're finished with nursing, can apply for a period of 28 months of working with a full capacity if they specifically fulfill some of the requirements based on their experience, based on the criteria that they have. And this is, as you would see, already the experience that is given through the European country, European Union included country, that is bringing most of the workload of the migrating crisis of migrants fleeing from Ukraine. So now finishing with the spot, what are the policy making in specialized universities implications? We could go in deep and suggest there are pros and cons throughout the comprehensive, non-comprehensive universities. Well, medically profiled, we are smaller. We might not be the biggest one, but we are then specific. But then we think about that not each country works in the same way. So we shall not think about all of the Europe as a unified, that is only having comprehensive universities as a basis for medically profiled students. And if we then go a little bit more further, so I would ask you to make a step further and just finish a little bit with the situation that we are imagining from Ukraine. the geopolitical situation, as Sandrine yesterday said, it's very fluctuating. And that's a pity, but we don't know what the future brings. If there are other countries that want to be included within the situation that is, and are not having the same requirements that we already have seen throughout the Ukrainian situation, are filling the gaps that we miss, there are exactly specific requests that have to be provided throughout the European Commission requests. And there is, if there are those requirements that the European Commission is asking are not fulfilled, there are two things to be done. To sit an aptitude test to check that the professionals have the skill required in chosen country, and complete an adaptation period based on the article of directive. So now imagine who's doing that. It's not government. These are the universities. So we are taking the workload, all of us, taking the workload of that situation and the application being recognized by the national authorities. And we're never going to be, I think, in the moment when we are going to say, yes, we are there, we've arrived, we don't need any more nurses, we don't need any more medical professionals. I might have some years behind me, but I have never heard any country having said that. So, but if we're saying that, even though if we have some differences between countries, there's still not, there's still a lot that we could say need to be done. So I wanted our voice to be heard, and also to represent, I think, our all ideas about that. And before that, I'm saying thank you, köszönöm, and
Thank you very much. And I think it was very important to say that we have this university project. Maybe we should have something over there, but we are in a hurry a little bit because we have the closing ceremony. We have to finish in time. Now we will try to share the. Sorry, I have too many things in my hands. Because our next speaker, Professor Holger Schünemann, is online, but we can see, Professor, your presentation. So the floor is yours, please.
Perfect. Thank you for having me, and apologies for not being there in person anymore. Travel back for pre-existing commitments. So I really appreciate you making this online presentation feasible for me. So my name is Holger Schünemann. I work at Humanitas University, where I'm a professor of public health and preventive medicine and the delegate for internationalization. Humanitas University is one of the associate partners of the UGLO project, or the UGLO initiative. And we are a health sciences-based university in Milan, Italy, where we have a big teaching hospital, as well as a national network of hospitals and a national research center. Just a few disclosures here. I will speak about WHO quite a bit because I'm doing work with WHO. I don't have any other direct financial conflicts of interest. And very importantly, there's a colleague at WHO that I've worked with very closely to present some of this work. And this work is focusing on strengthening countries' capacity in health guideline development and implementation. Here again is this colleague, and I'm basically reporting on a book that we published with WHO about a year ago. This describes how countries really should make decisions, and it's extremely complicated, obviously, not only globally, but in Europe alone, because the landscape of healthcare is really very varied in Europe, and evidence-based decisions need to be made in a very structured and consistent fashion. And health guidance or guidelines are one of the key tools to do that. However, few countries really have the capacity to develop guidelines, health guidelines from scratch. WHO's main mission is to develop guidelines as a big national global health organization. Countries often do that too. Professional societies do that as well. So we did a pretty big workshop with representatives from European countries in which we looked at what the capacity really would have to be and what countries need in order to move this forward. And so this was done last year. I'm going to present on some of that. One of the fundamental methods that WHO uses for the development of guidelines is called the GRADE approach, Grading Recommendations, Assessment, Development, Evaluation. They've been using this for over 20 years. So and whenever you see a WHO guideline, they typically use this approach for doing it. And very quickly, for those who were there on Wednesday, this is a brief repetition. The GRADE approach comes from the GRADE working group, which has for the last 24 years worked together to produce a unifying, transparent, and sensible system for rating the certainty of evidence and making decisions. This has been developed with major organizations globally. It is for synthesis, health technology assessment, and guidelines. It's been used in thousands, if not tens of thousands, of recommendations by players in global health. We've published widely lots of citations. There's a handbook, and this is now led from, I'm chairing this network and this group. This is now led from Humanitas University. And as I said, we are globally represented. You see that here on the map, and in particularly relevant is that we have the Scandinavian network is co-run or co-led out of Lund University, which is one of the partners, and we just last week approved the Portugal GRADE network that is led from the University of Porto, which is another player. Very quickly, so GRADE is really for critical thinking about health. We've defined criteria that should be considered when somebody makes a decision. These criteria, when they are used for decision making, should be informed by evidence from systematic reviews in order to then assess that evidence and make decisions in this context, including for health policy. Just very quickly, we did a big EU-funded project, a Horizon project, that established these evidence to decision frameworks from 2011 to 2015, and have since worked on a number of ways of implementing these frameworks and work with countries in particular. So one of the more recent outputs about a couple of years ago with WHO Europe and WHO Global, as well as the country office, looked at how decisions are made and how capacity can be made and can be created or strengthened in countries, and laid out the key concepts in that decision-making process. I showed this also on Wednesday very quickly. This is our infamous overview that describes that in a country, as well as globally, there are different players in the health decision-making ecosystem, where HTA and guidelines play critical roles for quality improvement, coverage decisions, and decisions about what are essential medicines, and making evidence-informed policy about health. Criteria are very similar across these different decision makers, so there's a lot of opportunity for harmonization. I'm going to focus on guidelines and HTA, which, as I said, are the primary pillars there. Of course, all of that is based on evidence from primary research that is synthesized in order to inform clinical public health and health systems decisions. So focusing on guidelines, in order for guidelines to be trustworthy, they should be made by multidisciplinary panels of experts and representatives, including patients and people with the conditions. They should be based on systematic reviews. They should be considering important population subgroups. They should consider people's values and preferences, and be based on explicit processes that reduce conflicts of interest as much as possible, provide a clear explanation of any logical relationship between the many alternative care options or policy options that exist, be explicit about the certainty of the underlying evidence and how it links to the grade or strength of recommendations, which is the grade piece here. And then, of course, they need to be kept up to date. I refer to this workshop and the implementation of this book. What we learned is that there is 4 in particular small countries, if they want to use products of big countries, the necessity and potential for contextualization. So that need is huge. There's going to be a lot of challenges, or lots of challenges in implementation of guidance that is developed by, for instance, Germany, and Estonia wants to take advantage of that and use this type of guidance, or the European Respiratory Society, and these guidelines are used in, let's just say, San Marino, which is a country in Europe, but a very small country. So that means that there need to be a lot of collaborative efforts, shared learning, and there in particular is a big role in continuous learning and capacity strengthening. I will go back to that with an underlying framework in this case. It's great. So this must be done. The use of guidelines, the development of guidelines, the adaptation and contextualization of guidelines must be done by professionally trained individuals with big networks such as the Guidelines International Network and partner universities. We've created professional programs so that people who develop guidance documents can be certified, because this is not being taught in medical school. So nobody taught me this in medical school, how I interact with different players, how I synthesize evidence, and how I make transparent decisions. So there's certification programs now, but all of that and the current organizations and networks are still not sufficient to deliver on appropriate guideline development and partnerships in Europe. Most of the collaborations are not official, and there's many small countries in the European region that we should be supporting. There's indeed 11 with less than 2 million people. So there's new structures needed, and with WHO we are looking at existing initiatives. So many of you may have heard of UNETA, which is the European, or was the European Network of Health Technology Assessment Units, and we're looking at these models to collaborate amongst the champions for good guidelines in Europe. There is 4 steps that we have envisioned so far, which is currently collecting and sharing country experiences and examples. So we are doing country work. We are providing joint capacity for strengthening opportunities, and develop and create material to share advocacy. We are addressing methodological questions, institutional questions at the country level, to co-create and update tools and provide those in a repository, and also create rosters of experts who want to participate. So this is an open call for joining in these efforts. And then obviously we are looking at new ways of identifying and applying for funding. So our direct next steps that is really open for a lot of collaboration are that we are finishing work on identifying barriers and facilitators, in particular in Europe. We're doing country work, such as with Slovenia and Sweden and Lund. We collect organizational structure data, and with the new collaborating center for WHO for technical support for all of that we are creating at Humanitas University, we are providing, as I said, the necessary methodological frameworks that WHO can use. So there's lots of opportunities for joint training opportunities. There's lots of opportunities for joint research opportunities to really look at what countries need in the context of health policy making, around guideline development. Basically every country from Ireland to every large country from Ireland to Spain have national bodies that develop guidelines, but they are not well enough networked to share resources in a nutshell, and that's what we are creating and working on to make this available for the public. Yeah, thanks very much for having me.
Thank you very much for being with us online. I hope you can see me a little bit. And as we say at last but not least, I would like to give the floor for our next and last presenter, sorry, who is coming from an old, who is coming from the University of the Juglo Alliance, University of Porto, and Professor, you have just put
somewhere here.
the floor, and if we are really putting
continence along the 6 years. No, but it is important to teach. And there are many schools that don't teach anything at all in terms of incontinence. And this is wrong because it is a huge burden for European Union.
I might also get to that if I can just briefly. Great. I think what we see a lot with sustainability and climate change topics, we try and just kind of integrate, for example, just 2 slides on a certain topic. And I think you presented the economic numbers really nicely. So if there was, let's say, some health economic training in the medical degree anyway, you could then bring it in as a topic. So it's just a refresher. It's not like deep and like there's not a lot of content in it, but it's just, okay, they had their 1 or 2 hours somewhere already, and then they'll be reminded, and it's just a cross-cutting topic that reoccurs. So I think to collaborate between the different components of the curriculum is really important there.
I agree. And if I can say one thing, because in the beginning we mentioned about physician associates, and this is one area where physician associates, if the medical councils will allow that, and that is a problem of policy of each country, that will be extremely useful because many cases of incontinence do not require a neurologist or a very high degree specialist or a surgeon. Prevention, for example, obesity, the prevention after the labor, after deliveries, and this is completely ignored by many countries, and it is not taught in medical schools.
Yes, please.
I would like to say that I really like our presentation, but I would like to put some question maybe to the discussion in case of the obesity, which was mentioned by Samira. I'm dentist, and I would like to underline that it is not so often mentioned dentistry in the role of the reduced weight in the patients. And we know that it is a very important group of the stakeholders or the doctors who can meet with the patients very often. Sometimes really it is quite often like in the case of the GPs. And the role of the obesity in case of the oral mouth is really high because we can meet the fatty tissue bone, yellow bone. We have the problem with periodontitis, not healing the bones after tooth extraction, and a lot of different questions. And it is also published a lot of good papers in case of the weight reduction and the role of obesity in dental teams. And I think we should put this group of the specialists in the group of the I can say not the specialists as the doctors, a group of interest stakeholders who are taking care of this topic. That's why I'm really interested in Poland. We are also put to the intention even in September we will have big I think conference in our government about all this type of the issue. So I only on this point I would like to underline that also it's very important that as a group of the physicians or as a doctors who should taking care of the obesity.
Thank you. You're absolutely right. I think dentists are very often kind of regarded separately, just simply because, well, they're trained separately, and you're so right. It's something that actually slipped our network so far. So if you were interested in joining us at some point, maybe during one of the webinar sessions, for example, to give that perspective, that would be very valuable.
With great pleasure.
Thank you.
You see, we have already a result of a new connection, aren't we? Are there any other questions? Because slowly the time is up, but I don't want to be an obstacle to the...
Thanks to all the speakers for the nice presentations. I have just one query to Professor Lisa. So in terms of the definition of so the physician associates, the PA until now, so who can be included or who can apply for the position of the PA?
Thank you for your question. Most countries require that the physician associate be trained in that country. Then, after they've finished their degree, are required to take a national registry exam. Once that exam is completed and successfully completed, then they can go into practice, but they must collaborate with a doctor. So they cannot practice independently. So does that answer your question about who can come to the program? Yes. Yeah. Yes. In our country, you must have an EU passport in order to study at the Royal College for the physician associate degree. Okay.
If there is no other question, once again the time is up, and in 10 minutes we will have the closing ceremony in the big room of this same building.
Okay.
Maybe with some minutes of pause. I would like to thank again Professors, Doctors, Professor Schünemann for being with us today, and thank you very much for the public. I have to say that I was surprised. I thought that last day of the summit, don't know, you were very dynamic, and it was a pleasure to be with you. I learned a lot, and not only about medicine, but also about policy. Thank you very much, and thank you. That's a little bit quick, unfortunately. No, but I prefer conferences when it's a little bit more time to discuss.
Thank you very much for the presentation. On behalf of the organization, thank you for your kind contribution.